Okay, we're back for the second video of our PAH bleeding. It started off we're still on first trimester, and then we'll go into placental problems and PIH. Just to finish up DIC, we know that these normals will be low platelet count for bleeding. Same with fibrinogen. Our clotting factors are all low. Red blood cells are reduced because of hemorrhage. We increase in fibrin degradation products simply because of the whole tearing down of the fibrinogen. It's due to fibrinolysis. The PT and PTT, our bleeding time, are prolonged because of the hemorrhaging. And then this is the interesting one that really kind of just says, yes, they have DIC, is the D-dimer test. It's very, very high levels in DIC because it measures fibrin protein activity. And we know with all of this going on, we've got a lot of activity. It's usually normally negative. So there you go with that. The treatment, of course, the only way to get rid of it is correct the underlying cause. Blood products, definitely a ton of them. Fresh frozen plasma. Any of the fresh frozen plasma is used to replace low levels of coagulation factors. Platelets may be given. Cryoprecipitates, what are those? It's they're coagulation therapy, and it has the factor VIII in it. So all of these are to try to maintain that whole hemodynamics that's now collapsing on us. They're going to have a regular IV of LR with giving fluids for volume, and then obviously oxygen. Heparin, they have to give heparin if they're giving all these clotting factors to balance it. Homan sign, I just want to talk about this for just a second. The research is showing that there are too many false negatives, meaning the person does have a clot, but yet the Doppler and our Homan sign, or actually, I'm sorry, the Doppler says yes, they do have a clot, but the Homan sign itself, where you dorsiflex the foot, bend it very severely up, like at a 90-degree angle, and they feel pain. And so they've gotten too many false negatives where they really do have a blood clot. And so in the research now, they say not to use it. I do know, though, at some of the medical centers, they're still using it. And I think, sometimes change is slow and they haven't had time to change their documents. But anyway, just to let you know that if they're not doing it, that's why. You can still dorsiflex the foot. If you see any redness or tenderness, you need to report it and possibly have a Doppler, especially if they have any pain. Okay, to look at habitual abortion, we've got a bunch of stuff that could be going on. The most common is the incompetent cervix, where they just can't stay pregnant. They may have, for the incompetent cervix, insufficient secretion of progesterone, and we know that's the hormone to stay pregnant. Immunologic factors can play a part, but the bicornate uterus, it's shaped like a crescent, and I believe, it's in your PowerPoint, not mine. The picture of it. I had to get rid of the pictures. They just don't transfer well on the little bit of videotape that I can do. Anyway, the bicornate, as you can see, it's shaped like a crescent. There's a bifid or a septate uterus, meaning there's a septum down in the middle, and you have two. You have one on either side. And sometimes even the cervix and or the vagina may be as double as well. They may have two of them with these bicornate uteruses. They're shaped like a crescent instead of a pear. And as you can see through the pictures, that's what happens. This is of no major consequence, except that in pregnancy, a bifid uterus may not enlarge normally, and so it leads to fetal loss. And you can see why. It's like almost divided in half from the picture. And then a cerclage, let's see what that is. And again, you have a better picture than I have here. It is where we sew up the cervix. We just sew it up so it can't open. And so by the picture, you can see it almost looks like a rubber band that girls you'd put in your hair, like a hair tie. And they put that in early, somewhere between 12 and 20 weeks, depending on the doctor and how far along they are when they go into the doctor. And then they snip it or take it out about 38 weeks, and because then the baby is viable. And some of them wait till 39. But anyway, great invention that they found. Okay, let's talk about ectopic pregnancies. An ectopic pregnancy, ectopic means outside. It's an implantation of a fertilized ovum in a site other than the endometrial lining of the uterus. And I actually have a great picture of this too, where you can see there's like 12 different sites where it can go. And that's an ectopic. Anything that implants outside of the uterus. The reason we refer to them as tubal pregnancies is because 90% of them implant in the fallopian tube. So it's any condition that diminishes the tubal lumen diameter, and that's why it gets stuck. It alters motility of the egg. It just gets stuck. It doesn't get to move, in through the fimbriae, through the tube, into the uterus and be implanted. Previous tubal damage, anything that's going to cause scarring, such as PID, pelvic inflammatory disease, STDs full of bacteria, and they can, and viral load, they can cause scar tissue. Congenital abnormalities of a tube, which they'll do studies over time. Endometriosis, presence of an IUD, in vitro and uterine exposure to DES. And the only reason I put in there just a little bit of a history lesson is DES is diethylstilbestrol. And what it is it's a potent synthetic non-steroidal estrogen that was developed and used widely for pregnancy symptoms from 1940 to 1971. So here this spanned 30 years. And drugs have to go for a length of time so you can see what the general population does with them. Well, unfortunately, this caused increased risk for reproductive tract abnormalities in the male and female. In the male, it caused epididymal cysts, hypertrophic testes, variceles, and altered the semen. And these are grown adults that the mother took this while they carried them. For female, it caused all kinds of cervical and uterine abnormalities, and can possibly cancer later on in life of the cervix and uterus. It also caused altered fetal death and childhood malignancies. So, just another reason I point that out, just don't take anything while you're pregnant. Signs and symptoms, I think this still works. But anyway, of a tubal ectopic pregnancy, and this kind of shows you that, are missed menses and early signs of pregnancy, because that's how we know they're pregnant. But a lot of times, and these are what ER nurses need to be aware of, a one-sided lower abdominal pain or diffuse lower abdominal pain, abdominal adnexal tenderness, very, very tender in the lower region, and spotting. They're going to rule out an appendectomy, but we always, if they're a woman with childbearing years, an ER doctor needs to be cognizant enough to say, do you think you could be pregnant? And they may say no, but I would still run the pregnancy test. Cullen sign, what is that? We talked a little bit about that in patho. It's a bruising or blue-black pattern that you can see on the skin around the umbilicus, and it usually lets like a GI guy or internal medicine know that there's a pancreatitis going on. But the guy that actually discovered this, his name is Thomas Cullen. He was an obstetrician, and all the way back in 1916, he found that there was a bruising blue-black pattern noted around the umbilicus of a ruptured fallopian tube. So there you go. Cullen, it was an OBGYN. Dizziness, fainting, referred right shoulder pain, it may be, or subdiaphragmatic phrenic nerve from that. If hemorrhage is profuse, we need to look for hypovolemic shock, again, elevated, thready, quick, high, fast tachycardia, I can't come up with the word, pulse, and a low blood pressure. If slow bleeding, they can have a rigid, tender abdomen. And then here is a really great picture of what happens. It gets implanted, and over time, it's going to just, as it gets bigger, it's not going to make it, and it's going to rupture. About 1 in 150 pregnancies results in ectopic implantation. So there, we really do have to know how to treat it, how to recognize it. And again, often about 6 weeks after a previous menstrual period. So not that long, because the tubes are like little string beans. Patients presenting with ectopic pregnancies may be acutely ill. This is definitely a medical emergency because of the bleeding. Nursing interventions, what are we going to do? Well, we need an IV, we need baseline vitals. Obviously, we need identify to prevent hypovolemic shock for the vital signs. An ultrasound, are they pregnant? Where is the implantation? We need all kinds of labs, especially if they're going to be going to surgery with an H&H, because we need a baseline if they are bleeding. NPO always if they're going to surgery. Consent always if they're going to go to surgery. Control of pain. They are going to be in substantial amount of pain. All right, and here's some pictures that you can see in your picture. Unruptured on the left side, and right is a ruptured one. And then this one, you can see the twin fetuses at the lower right. And I just wanted to say it is one of the primary causes of first trimester maternal mortality. And that ends this section. We will go on with trophoblastic disease on the third video. Thank you.